Morning. Welcome to another session of our course in clinical epidemiology. So today we will be critically appraising a diagnostic study. So we have done this in the past, but it has been quite a while. So we thought this would once again be a refresher. We thought every time we do a critical appraisal of any new studies, there will be something new out of it, something unique out of it. So last time we did a star B checklist for a diagnostic test. That is a reporting guideline, meaning someone who is going to do a diagnostic test and a researcher who is doing or reporting a diagnostic study will have to conform to the guidelines of the star B checklist. As a user, if someone is reading a journal article on a diagnostic study, as a user, we are supposed to critically appraise it. So it is just looking from another end. So that checklist is from a researcher's end. This is from a user's end who's reading the literature. So today we will be looking at such a Casp checklist. We have used Casp checklist for various other study designs prior. So today we use the Casp checklist for a diagnostic study. And it's my pleasure to introduce welcome Dr. Anuka, who has once again taken all the efforts to present a diagnostic study critical appraisal using the Casp questionnaire. So I'll hand over to Dr. Thank you.
Good morning. Today we will be doing the critical appraisal of a diagnostic test. So we've been researched before, we have done this before and gone through the concepts. So today we will just revise some concepts. So we will start from the end. So in a diagnostic test, when we critically appraise it, what do we look at? So we look at two things prominently. Mainly, it is internally valid. If so, then we look at how does it apply in the clinical setting, either at a population level or at a patient level. Now, to look at internal validity, we need two things. It should not be biased and it should be precise. So these are two things which will actually make up the internal validity for a diagnostic test. We will go from the outcome. So in a diagnostics, like how in RCT, we have a primary outcome, secondary outcome. In a diagnostic test, outcomes can be of different types. It could be a dichotomous outcome. For example, a test might be just positive or negative. So the result will be only two results. Or it could be multi-level test. It could be multiple outcomes, or it could be continuous outcome. For example, NT-proBNP level in a heart failure can range from 500 to 3000 to 5000. So most common tests which we have are something with a dichotomous result. In that we can calculate the sensitivity, specificity, the positive or the negative predictive value, and the likelihood ratio. So today's test also shows this. So we will be discussing this in detail. Just a basic. So suppose we look at this diagram. Green are the people with disease. Pink are the people whose test has shown positive. So this will be the, among the total population, this would be the false positive. This will be the true positive. The test has picked up people with disease. This would be the false negative. And this would be the true negative. These are the four outcomes which we get. And based on that, we can calculate the sensitivity, specificity, positive and negative predictive value in a 2x2 table. So in the top of the table would be disease or the gold standard test, positive or negative, and the index test which we are testing, positive or negative. So sensitivity is proportion of true positive in people who have disease. Specificity is proportion of true negative people who don't have the disease in the people who don't have the disease. And the predictive value talks about the test. So true positive in all the patients whose test has come as positive. Similarly for negative predictive value. We'll just look at this in detail. So when you interpret a diagnostic test, some reports tells you the accuracy of the test, how good the test is. That is the sensitivity and the specificity. For a test, that usually remains the same. It depends on how the test is made. So it depends on if the test was tested among patients with different severity, or they have taken only sicker patient, or for example, in a patient with CA stomach, if they have looked at the biomarkers only in patients with diabetes, the sensitivity will be very high. But if you take a mix of disease, the clinical spectrum, the sensitivity will change accordingly. Now, this test predicts the population, how the test works in a population. So it depends on the prevalence or the pre-test probability of patient having the disease. That determines what is the positive or the negative predictive value of the test. Now, what is sensitivity, which we already discussed, the proportion of people who actually have the disease and is correctly identified as positive test. How to remember that? So, one of the acronym is now sensitive test, if negative, will rule out a disease. Sensitive test, if negative, will rule out a disease, or PID or positive and disease. Sensitive test will always be positive and disease. Specificity is the patients who don't have the disease and test has also said the two negatives, proportion of two negatives in a patient who don't have the disease. That is SPID. Specific test, if positive, will rule in the disease. That is negative in health. Just look at it with an example. Suppose this is a data set in which blue or purple are the patients with disease, orange are the people without disease. Now, if we have a perfect test, which specificity, sensitivity, both are 100, it will correctly predict positive, correctly predict negative. Now, suppose if you look at this test, in which sensitivity is very good, 100%. We said sensitive test, if negative, will rule out disease. Sensitive test will pick up all the patients with the disease. So it tells how it identifies people with the condition. A highly sensitive test will not miss people. Now we look at this third example. Specific test, let us suppose the specificity is 100. Specific test identifies people without the condition. For example, specific test is positive if you have a disease. So specific test, highly specific test will not falsely identify people as having the condition. So one acronym to remember is patient's count. Whereas the predictive value, so if you look at this test, the sensitivity and specificity will be same. But if the prevalence increases, the positive predictive value of the test will increase. That will change the diagnostic accuracy. So the predictive value depends on the prevalence of the disease where the testing is done. Now coming to, so we could get the outcome of sensitivity, specificity, predictive value, positive, negative. But to derive a test and looking at the sensitivity, first the caveat is there should not be any bias in diagnostic study. So what are the probable biases which can arise in a diagnostic studies? Now the biases can be there in various levels. It can be there when the patient is selected. It can be there with the index test which is tested, or it can be there how the disease is verified. So there are different biases. We will look at it. So first we'll look at what is partial verification. So what is verification bias? This is complete verification. All the patients, they undergo the test which you want and they undergo the gold standard. It's complete verification. There can be deviation to that. All the patients who undergo index test, if it's positive, we'll have the gold standard. Negative will not have. So this is partial. What is differential verification? Positive people with the preliminary test, index test positive, get different treatment done, different confirmatory tests. We'll look at this with an example which I've taken from the core IL. So verification bias. Suppose we're looking at colonic polyps. So your index test is a fit immunochemical test, something like a test which looks at the blood and the stool. Now, suppose if the test is positive and they undergo colonoscopy, but the test is negative and they don't undergo colonoscopy. So this is called partial verification. Only if the first test is positive, they undergo the final test. This is partial verification. Or in another scenario, suppose a biomarker, if it is positive, then they undergo biopsy and pathology. But if the biomarker is negative and they undergo clinical follow-up, this is called differential verification. Now, what is the issue with this? If you look at partial verification, it has some effect on the sensitivity and the specificity. So if you have a test which is positive and you undergo colonoscopy and you have got polyp, you have to identify the disease. But if the test is negative and you have not verified it, we have an unverified disease status. We do not know what has happened to that population. So the false negatives will be less. If you remember the 2 by 2 table, if the false negative will come as down here in the 2 by 2 table, negative will less, sensitivity will go up. Similarly, if your true negative is less, your specificity will come down. So if there's a bias because of partial verification, there will be more test sensitivity will go up, but specificity will come down. Another type of bias is spectrum bias. So spectrum bias is if the disease spectrum is not as like the clinical scenario or what we see in practice. This is the spectrum bias. So there can be different types of spectrum bias. It can happen due to predominantly three things. We will look at that. So one is how you take the sample for your testing. So we can do a cross-sectional cohort design, that is you take all the patients with and without disease. So you'll get something like that. People with disease, without disease, and some in between patients who are ambiguous. If you take a case control, that is you take a patient with disease and patients without disease. So you will serve the center people. So we do not know how the test acts in those people. So it's the same thing. If we do this, we take two different, like a case control. This one is here. So we will get two different positives and negatives, positives and negative. We will get sensitivity and specificity of this test, but we'll not know how is it doing in the whole population. Whereas if you take a case control study or a cohort study, cross-sectional study, if you take all the patients, we can also calculate the positive and negative predictive value. We'll have an idea of how is there in the community. So this will help us to calculate predictive value, which depends on the prevalence. So this is one of the spectrum bias, how the patients are collected. Second is convenience sampling. So we know that there's a huge spectrum of disease. There are sickest of the sick and there are well people. So which patients you use to test or test the validity of the test depends on, will also affect the sensitivity and specificity. We'll see an example. So this is a evaluation of patient with stroke based on the MRI. Now we know in clinical disease we have a spectrum. We have some patients who come with exact phenotype of a clinical phenotype of a stroke. We know they have stroke. Some people we don't have stroke. Some people will be borderline, which we are not sure if they have stroke or not. So this looked at ischemic infarcts in patients who presented with probable diagnosis of stroke. Now, this orange bar is your sensitivity specificity if we take the whole spectrum, full spectrum. But if we take only the extremes, then your sensitivity specificity falsely goes up. That is just because of the fact that you have not chosen the correct spectrum. The same in the same study, if you take the whole spectrum, you can see the sensitivity is around 90 and specificity is 87. But if you remove the uncertain cases in between people, then your sensitivity and your specificity goes up. Similarly, this is if you do a case control design, that is, you take only the cases and control, your sensitivity and specificity goes up. But in a clinical scenario, we will normally have a full spectrum of disease. So to avoid spectrum bias, normally you should take consecutive, prospective, you should take the patients. Next would be interpretation bias. So that depends on how the test report is reviewed. Now, if we have a patient, if suppose in a study there's an index test and a final gold standard test, the report of the index test should be done independently of the report of the final test. If suppose the report of the index test is known to the person who is assessing the outcome of the final test, there will be some bias. That is called the review bias. It can be avoided by doing a single blinding, like they don't know what the index test is, or double blinding, they don't know what the index test is, or the final or the outcome is. So this is something that can be avoided by doing a blinding. Next is what do you do with the indeterminate test? Sometimes it will be positive. Suppose I have an expert TB set, it may be positive, it may be negative, it may be indeterminate, or some data will be missing. So if you take all of them, this is how you would get. So this is a patient study done on pulmonary embolism and BQ scans. If all the tests if you do, this is how you will get some sensitivity of 81. All the patients are included, 81%, 84%. But if you exclude the indeterminate test, if you have not did them as positive, negative, indeterminate test, then your sensitivity specificity will falsely go up. So indeterminate tests is usually to be accounted for in the analysis. What happens with the missing data? So normally, according to this, instead of a 2 by 2, there should be some 3 by 3 table. If the missing data has to be imputed or accounted for. Last is the verification bias. So we looked at differential verification when they get two different gold standard. It could be also incorporation bias. Incorporation bias is your final test is also similar, same as index test. Then your sensitivity goes high because both the tests are doing the same thing. This is incorporation test. Now to summarize, if you have some bias, that will result in a false diagnostic accuracy or diagnostic or sensitivity and specificity. You can have based on how you've taken the patient. You can have because you have taken a different reference test. You are not blinded. You are not taken consecutive. You have done a retrospective. You don't have a good test. You don't have a good described population. You don't have a reference test. It's the same thing to show. So in this, if you take cases and control, it might be different. But if you take everybody, if this the first one is a case control, healthy controls and cases. But if you take a spectrum, the report will change. Similarly, if there are some bias, the first part of your internal validity will be affected. Now, going through the concept, we will go to today's study. We will look at two cases. Suppose there are two patients come to you when you are sitting in medicine OPD. First is a 50-year-old man who has come for hypertensive evaluation. He is on 4 antihypertensives, has a hypokalemia and low potassium, and you ruled out other causes of hypertension and you're thinking of the resistant hypertension. So you do a hormone test, aldosterone renin ratio, which is high. So you are thinking of primary hyperaldosteronism as one cause of hypertension for this patient. Suppose you get another patient who is also 50-year-old, has come for hypertensive evaluation, is already on 2 hypertensive and is floridly Cushing. Apart from these other causes, he has come to rule out other causes of hypertension. You have done a ARR, an aldosterone renin ratio, that is mildly high. How would you proceed? So you know that ARR or the hormone test which you do, if it is not well done, can have a false positive rate of 50%. So you being the active physician would refer the guideline. So guideline will tell you if you screen and if your ARR is high, the next step is to confirm if there's a biochemical hyperaldosteronism. You can do confirmation by either of the 4 tests. And then once you confirmed it, you would proceed with the subtype evaluation. What is causing it? So what would you do for the patient? For this patient, for both the patient, would you do the confirmatory test? To answer this question, we will look at this study which looks at confirmatory test for primary hyperaldosteronism. I will be using this critical appraisal skills program checklist to appraise this. So we know that if there's a primary hyperaldosteronism, there's a curable cause of hypertension. You can even cut down on antihypertensive. There's a targeted therapy for that. And based on the current algorithm, if your ARR is high, you need to do a case confirmation followed by the definitive management. Here they're looking at one of the tests, the seated saline suppression test, how good it is as a confirmatory test for diagnosing primary hyperaldosteronism. So question 1, did the study address a clearly focused issue? So the population they had taken were adults who had positive ARR and were tested for positive ARR for primary hyperaldosteronism. In this test was a seated saline suppression test and they used 2 assays. The reference standard, so we know there's no other gold standard which can be used. So they looked at treatment response, both clinical and biochemical treatment response after the treatment. And outcome they looked at all the diagnostic accuracy markers. This was done at the Regional Endocrine Hypertension Clinic in Canada, funded by Canadian Institute of Health Research, Hypertension Canada, and Heart and Stroke Foundation, but they had no role in the study or design. It was conducted between 2017 to August 2024. It's important because COVID was there in between and they had some issues with the measurement or with the BP measurement. We'll come to that. So was there a comparison or an appropriate reference standard? Yes. So the reference they used was treatment response, both clinical and biochemical. So this is how they defined the outcome. So we know that in a treatment of primary hyperaldosteronism, you can have unilateral disease or bilateral disease. If you have unilateral disease, usually the treatment is surgery. Bilateral disease, it's a medicine, mineralocorticoid receptor antagonist. So they had defined response based on what treatment the patient got. If suppose they had surgery, they had complete responders whose BP normalized without requiring medicine. Then they had definition for partial, that is reduction in the BP or reduction in number of drugs. For people on drugs, the response was any reduction in BP or the reduction in the number of drugs. The people who underwent surgery had also they looked at if the hormone ARR ratio had come down after surgery. The clinical outcome was tested 6 months after the treatment was given. So the outcomes they had put as responders who had responded to this or non-responders who showed no response. Did all the patients get the diagnostic test and reference standard? Yes. So they got both the tests. So the population who was screened had a screening ARR test. Then they had the confirmatory test. This is the test in the index test here. So they had a washout period and then a confirmatory test. And whether it came positive or negative, all of them had a cross-section imaging adrenal vein sampling based on that unilateral versus bilateral underwent surgery or medication. So this was the treatment pathway. If we look at the flow diagram, so they had 183 people who had identified, and the first index test was they were referred 177 was referred for the index test. Out of which only 166 people have completed the index test. But the people who underwent the definitive test, that is the final treatment response, was 165. Out of which outcomes was not 165, out of which outcomes were not available in this patient. The final patient number of people who had undergone both the tests was 156. There was some missing data of some people who underwent the first test but not the second test. This was probably because of the COVID pandemic which was happened before in between. So, but they have included all the patients who had both the tests done. So, among the patients who underwent the final response, they divided as positive and negative based on index tests. So, could the result of the test have been influenced by the result of the reference standard? No. So, here the treatment assignment and the outcome assessment were blinded to this. So, they were not aware of what was the outcome of the saline seated test, suppression test, and they were not aware what was the outcome, the clinical outcome which was done 6 months later. They were also not aware of the test reports. Question 5. Is the disease status of the tested population clearly described? So this was done at a very specialty clinic, endocrine hypertensive clinic in Canada. They have taken all the consecutive patients. They have done a prospective recruitment. Now, this was the population they had screened. So people with hypertension with elevated ratio who were suspected to have primary hyperaldosteronism based on the clinical features of resistant hypertension, which they had defined either requiring 4 drugs with controlled BP or more than 3 drugs with uncontrolled BP, or hypokalemia or adrenal nodule, and they're willing for surgery. So they're quite reasonable inclusion criteria. They have some exclusion criteria. So chronic kidney disease, decompensated heart failure, chronic edema, probably because they may not tolerate the 2 liter of saline suppression test. They also have taken people with uncontrolled hypertension, untreated hypokalemia. Untreated hypokalemia might interfere with the assay, aldosterone assay, and other causes, Cushing's and Fuhrman's. And this was the baseline characteristics of the patient. This were the overall patients. This is the responders. Responders are 142 and 14 were non-responders. So their mean age was around 50. Here it might be lesser than that. More male gender, different ethnicity. BMI, average BMI was 31, around 30. So they have given details on what was the potassium and renal parameters of the urine proteinuria. They have also defined the aldosterone renin ratio and all the drugs the patients were on. Also looked at identified people who had high risk of primary hyperaldosteronism, and also they have reported the comorbidities and what is the imaging findings. So next question, were the methods for performing the test described in detail? Yes. So it was a seated saline suppression test. They have described the full protocol. So in this test, patient is seated for 15 minutes. After that, 2 liters of 0.9% saline is transferred over 4 hours. test is usually done in the morning, and post infusion aldosterone is measured. They use two different assays, immunoassay and liquid chromatography. They had checked the aldosterone value before and after infusion, and this was done after a washout period. And they are describing in detail how they have done the testing. So they have used two immunoassays. The first two different assays. The first immunoassays has poor analytic specificity in some studies. So they had also done the gold standard, which is a liquid chromatography. So the cutoffs are different for each. Immunoassay is 142 to 280, and for LC it is 162. They have also described how they have done the clinical outcome, which is measurement of blood pressure. So most of them, there was a standard way to measure. But during the COVID, some patients could not come for measurement. So they have taken the ambulatory BP measurement. So they have actually mentioned, but those numbers were quite few. They have also given how the medicines were prepared. They have given how the lab was done. They have given how the adrenal vein sampling for the definitive treatment was done. So we look at the internal validity. In the methodology, they have done a cohort, they have done a cross-sectional study, they have taken consecutive, prospective, they have done a blinding, they have a gold standard, they have done complete verification, they have done washout period, and all outcomes were reported. So internal validity looks quite good. Few things which are not there. One is missing data, but there were only few patients. Measurement by, because one of the clinical outcome was reduction in hypertension. So few patients were measured by the ambulatory BP, but numbers were quite less. We do not know if that has caused any bias. So we'll go to the next session, which is the results. So this is the performance of the test based on the immunoassay. So the cutoff for immunoassay was from 140 to 280, around 300. And these are the different sensitivity and specificity at different values. If you look at the value at 140, the sensitivity is 93, but the specificity very less, 21%. Around 7% chance is still there that you might miss out patient with disease. But as you come down, your sensitivity, or if you want a good specificity, because this is a confirmatory test, you want a good specificity. If you come, the best specificity you're getting is only 57.1%, but you are coming down on the sensitivity, which is around 59%. So here the total number of patients which we looked according to the algorithm was 156. They have also given based on the other assay, but here I think the number of patients were 158. Maybe those patients underwent by this assay. Here the cutoff was 162. And if we look at that value, the sensitivity is only 57% and the specificity is 66.7%. Not good for a confirmatory test, maybe not even great for a screening test here. But I think the best if you want would be 92% sensitivity based on this test. Just to come to the 2 by 2 table at 1, so this is at 162 assay level. So here the sensitivity is coming to around 57 and specificity, and this is the positive and the negative predictive value and the likelihood ratio. So how good are we? How sure are we about the test? So the best sensitivity you're getting is 93%, but your specificity coming down, and if you're looking for a good specificity, your sensitivity is low. So this is the values we have got here. What are the cost of alternatives? So if the alternative is do the definitive test, adrenal vein sampling and a CT abdomen. That we know is an invasive test and a quite expensive test. Will these results help locally? So can the results be applied to our population of index? So this is the overall. So age probably same, maybe little less in our settings. Ethnicity is different. The BMI is little more than what we see in our setting. But everything else seems to be same. We also have people with these renal parameters on multiple drugs, high risk features, comorbidities, adrenal imaging. Only other thing is they had a lot of 29% of people with OSA and a lot of them were using a positive airway pressure. They were using a CPAP, which we probably will not see in our setting, may not really help with the blood pressure control maybe because of this. But other than that, more or less similar to what we see in our setting. Can the test be applied to your patient or population of interest? So our patient will come to a clinical state, but in our population, we have the resource to do a seated saline suppression test. It's just infusion of the saline followed by aldosterone testing, which we already do. But based on this test, even if you're looking at the best sensitivity, it will add complexity and time and may not give us much benefit. Where all the outcomes important to the individual or population considered, so they have looked at clinical and biochemical outcome, but they're not really mentioned about the adverse event of test. They've not mentioned if they tolerated the 2 liter of saline, was there any complication, those things they've not mentioned. They've not discussed the economic outcomes, and they've not really talked about the indirect medical costs, the economic aspect of it. So what would be the impact of using this test on your population? So this is the sensitivity and specificity we have. This probably cannot be used as a confirmatory test, probably as a triage test as how it is in the guideline. But if you look at a patient clinical scenario, we would also look at the prevalence or the pre-test probability. And if you're using that, probably this test really doesn't have much role. So coming to a clinical dilemma. So we have two gentlemen, both of the same age and male. If we look at both the patients, if you look at the first patient, your pre-test probability is quite high. So let us say around 80%. And if you look at the second patient who has an alternative diagnosis already, you've got Cushing-White syndrome. This is ARR is only mildly high. Your pre-test probability is quite low. But for the sake of maybe around 20, but for the sake of this, let's say it's around 40. So how do we proceed? So we can use a Fager's nomogram. So that helps us to determine the post-test probability. So we know probability, your predictive value depends on the probability. Post-test probability of the disease based on the likelihood ratio. So this ratio is calculated from the test which we looked at, reports which we looked at. So we said positive predictive, first case, pre-test probability of 80%. 80%, what is the probability of him having the disease? So likelihood ratio is 1.47, that is some 1.72, that is somewhere here. So your post-test probability also go to maybe 80, 90. The post-test probability also maybe increase only by 10. But we are interested in the negative likelihood ratio, 0.64. So around 80%, this would be around 0.6. So negative is also maybe 70, doesn't really bring it down. So the first patient, because a high pre-test probability, you would probably definitely proceed and not do the confirmatory test. What about the second patient, which the pre-test probability is ambiguous, suppose 40? We look at the likelihood ratio, so around 40, 1.72. So it actually increases only by maybe 10 to 50. And what is the probability of him not, clinical probability is high, what is the probability of him not having the disease? 0.67, 40 to 0.6, maybe around 35 or 30. It doesn't really help us by giving a low post-test probability. So for both the patient, I would still go clinically. First patient, I would definitely proceed. Second patient, I would probably not do a confirmatory test and keep on follow-up. Thank you.